Okay, we're ready to go live again. Thank you all for getting back promptly after the break. Pleased to turn it over to Dr. Martin Voss and Dr. Yip on the Trials in Progress session. So turn it over to you, Martin.
Thank you so much, Brian. So thank you. Welcome to session 4, everyone. Can you talk with the mic?
Talking.
Yes. Better? Can we get started? You want us to keep going? Okay. Very good. All right, welcome to session 4, everyone. So that session was the rapid abstract session. This one is sort of the lightning round session. It's exciting. So we have 3 minutes for introduction, 12 minutes for 4 talks, and then 15 minutes for discussion. I'm just going to keep talking. Magic trick. Okay, good. So my name is Martin Voss. I'm a geomedical oncologist, and I'm co-chairing the session with Wesley, who's one of my surgical colleagues at my own institution, Memorial Sloan Kettering Cancer Center in New York. We have 4 presenters, and we are talking about investigator-initiated trials. So this is an exciting session. We have a tight timeline and a microphone that we're going to pass around. With that, I'm going to hand it over to Wesley to introduce the speakers.
All right, so our first trial in progress is a phase 1b/2 trial of ipilimumab, a adenosine receptor antagonist in first-line advanced renal cell carcinoma by Dr. Beckerman.
Thank you. Is my mic working or how's this? Yep, loud and clear. Okay. Hi, everyone. My name is Katie Beckerman. I'm at Vanderbilt University, and it's my pleasure to be here. Thank you to the organizers for inviting me to present this phase 1/2 trial of ipi/nivo and ciforadenant in patients with untreated clear cell renal cell carcinoma. This is the first interventional trial that will run through the Kidney Cancer Clinical Trial Consortium funded by the DoD. And I want to thank my co-investigators for their feedback on clinical trial design and development of the protocol. Here are my conflicts of interest. So we hypothesize that adenosine, which we know in kidney cancer specifically is quite high in the tumor microenvironment and provides immune suppressive signaling. We hypothesize that we can modulate the immune suppressive signaling by blocking adenosine and adding to the efficacy of ipi/nivo. We can additionally capture more patients who will respond to ipilimumab and nivolumab, and we also hope to decrease resistance that may develop through the adenosine signaling pathway. So as shown here in this pictorial representation, adenosine is known to block T effector cell function, to decrease natural killer cell function, as well as to provide actually enhancing cell signaling to myeloid cells, myeloid-derived suppressor cells, and M2 macrophages. So CPI 444, which is an oral small molecule inhibitor, also known as ciforadenant, blocks the adenosine 2A receptor.
It's just little things.
Ciforadenant has already been published by Dr. Fong and colleagues in a clinical trial that tested in either monotherapy or in combination with PD-L1 in the 3rd or 4th line setting for refractory patients with metastatic RCC. You can see here on the left, the objective response rate in monotherapy was 3% in this refractory setting, with a 6-month disease control rate of 17%, and in the combination arm with PD-L1 was an 11% objective response rate and a 39% 6-month disease control rate. I really want to commend my colleagues for all the translational research that came out alongside this clinical data. They found, using pre-treatment tissue and gene expression signatures from a predefined adenosine high signature that you can see here in the top gene expression data, that if patients had that high gene expression signature on the bottom right, those patients tended to have disease control or tumor shrinkage. Also interesting, there's a fair amount of overlap between the adenosine high signature and the myeloid inflammatory signature that we know and have seen in Emotion 151 that was associated with a decreased PFS. So again, going to the rationale that we're hopeful that the addition of adenosine inhibition to ipilimumab and nivolumab will enhance efficacy to checkpoint inhibition. So the clinical trial design here is a phase 1/2, again, in untreated metastatic clear cell renal cell carcinoma. We'll have a safety lead-in of 8 patients. starting with ciforadenant, 100 milligrams POBID that was previously shown to be safe and efficacious in the prior combination with PD-L1 inhibitor trial. We have a dose de-escalation plan as needed for dose-limiting toxicities, and then phase 2 will include a total enrollment of up to 51 patients to look at efficacy with an interim Simon two-stage design to look at futility after enrolling 28 patients. And the primary endpoints in the phase 2 will be assessing the percentage of patients who achieve a greater than 50% tumor shrinkage that we know and understand from Checkmate 214 shows durable control for patients who are treated with historical IPI and NIVO. Secondary endpoints listed here, and then we are also excited to include exploratory analysis looking at gene expression profiling and peripheral blood markers. And I think I did it in 3 minutes.
Hi, good afternoon.
Okay, sure. Thank you, Dr. Bickerman. So our next trial is the APART trial by Dr. Ravi from Dana-Farber.
Thank you. Good afternoon. Thank you for the organizing committee for giving us the opportunity to present this today. And thank you to Brad McGregor, who's the overall PI, for allowing me to present on our behalf. So this is APART, phase 2 trial of axitinib, palbociclib, and avelumab as renal cell carcinoma therapy. So what is the background for this? So it's clear that, from today's meeting and beyond, that new targets beyond TKI and immunotherapy are needed in RCC. And the cell cycle pathway represents one such potential target. We know that from TCGA, CDKN2A inactivation or hypermethylation or mutation is reported in about 1/6 of RCC. And loss of 9p, which is a chromosomal location of this gene, was found in 40% of localized RCC in retrospective data. And the overall pathway is that VHL, when it's active, downregulates HIF, which the downstream targets of which include cyclin D1 amongst others. So in kidney cancer, when you lose, in clear cell kidney cancer, when VHL is lost in the majority or vast majority of patients, you will get upregulation of cyclin D1 as a result of constitutive HIF activation. So the rationale for this trial is, why do you want to combine IO with CDK4/6 inhibition? So firstly, RB is intact in the vast majority of RCC. You need RB to be intact for a CDK4/6 inhibitor to work. And there's preclinical evidence, predominantly from the breast cancer literature, that there's synergism between IO and CDK4/6 inhibition. CDK4/6 inhibition also leads to upregulation of PD-L1, and in melanoma, genomic aberrations in the CDK pathway were associated with resistance to immunotherapy. So the combination of axitinib and avelumab, we all know, is FDA approved in advanced clear cell kidney cancer. The combination of avelumab and palbociclib has been evaluated in non-small cell lung cancer. There was a phase 1/2 trial recently published, and in this trial, the maximum tolerated dose of the combo was avelumab at the standard dose, axitinib at 5 milligrams twice a day, and palbociclib 75 milligrams day 8 to 28 of a 28-day cycle. There were no DLTs at this dose. Interestingly, the recommended phase 2 dose moving forward in lung was 3 milligrams axitinib, but at this dose of 5 axitinib, key grade 3/4 toxicities included cytopenias, hypertension, and in a minority of patients, diarrhea. In this trial, amongst, I think, 15 patients, 27% of patients had partial response, including patients with prior immunotherapy and more pre-treated in prior lines of treatment. So the schema is as follows. So this is untreated first-line advanced clear cell kidney cancer, any IMDC, ECOG 0 to 2, adjuvant immunotherapy is allowed provided more than 12 months have elapsed, and it's a 25-patient trial. The study drugs are axitinib, avelumab, and palbociclib, and we have embedded into this trial research biopsies at baseline, as well as on treatment and at progression. They're optional, but we encouraging patients to do these, as well as research blood. And the research blood is to assess a biomarker called serum TK1, which is basically a liquid biomarker of Ki67. It's been evaluated in breast cancer. It's actually a CLIA approved test now. And the research biopsies in collaboration with David Braun are specifically to look at expression of ERVs, endogenous retroviruses, which we learned about earlier today, which are associated with response to IO. There's evidence that CDK4/6 inhibition may upregulate ERV. The endpoints, the primary endpoint is overall response rate, and the trial of 25 patients is 85% power to detect an improvement in ORR from 50%, which is that seen with axiavelumab, to 75%. It's a big signal, but you want a big signal to see whether this triplet might be active. And that's a one-sided alpha of 0.05. Secondary endpoints are the safety in kidney cancer. We've seen it in lung cancer, the rate of CR and deep PR, i.e. greater than 80% reduction, and PFS and OS. And the exploratory endpoints are to look at immunologic and biologic correlates of response and resistance to therapy. The trial opened September 2022. It's across 4 sites and is started to accrue patients. Thank you.
All right, to try to stay on time, we'll go up next to Dr. McGregor, also from Dana-Farber, with cabozantinib and ipi/nivo in advanced RCC with variant histology.
Thanks so much, and thank you to the organizing committee for the opportunity to present our trial in progress. So I was given 5 minutes 2 weeks ago to discuss all updates in GU cancer from the past 3 years. So doing 3 minutes for one trial sounds like a piece of cake. And if you really want more information about this, feel free to talk about this on the run tomorrow morning. The inaugural Rock the Run, 6 a.m. walkers, 6:30 go for a run. So everyone will be there. So you can always talk trials in progress on a run. So with that, so this is a trial we call CANI, Cabo, Nivo, Ipi in advanced RC with variant histology. And on behalf of my co-investigators across several sites to include Dana-Farber, the Harvard Cancer Consortium, UT Southwestern, Emory, and UCSD, I'm happy to talk about this. So I think we can all agree that RCC with variant histology is an unmet need, and we made a lot of progress. I mean, initially we had Aspen, ESPN, but now we have data from retrospective series showing cabozantinib, response rate is close to 30%. Then we had the amazing data from PetMet, randomized phase 2 showing a response of 23%. Then we had data for IO with pembrolizumab, 26%. You know, the data for Nivo/Ipi hasn't been as impressive. And then we've had a lot of trials looking at the roles of VEGF-IO, starting with Atezo-Bev, 26%, Cabo-Atezo, and even more recently we had Lem-Pembro presented at ESMO just recently, with responses close to 50%. So certainly we've made a lot of progress, and you know, the question is always can we do better? And so sort of inspired by Cosmic 313 with the hope that, you know, cabozantinib plus nivolumab and ipilimumab was going to improve versus nivolumab and ipilimumab, we developed CANI. So here was the initial protocol. So again, we looked to enroll 40 patients with any variety of any variant histology. Patients would undergo a mandatory pretreatment biopsy, receive Cabo 40 with Nivo/Ipi, followed by maintenance Cabo/Nivo. Primary endpoint was objective response rate. Secondary objectives were toxicities, duration responses, and overall survival. And at this point, we actually have 37. I did the slides a week ago. We actually have to 38 at this point in time, which is fantastic. And you know, I think we always want to try to see, should we change things up? And so obviously we had the presentation from Cosmic 313, met its primary endpoint, but you know, there were certainly toxicities. And so as we see here, you know, I think notably was the Lft toxicity. So the question is, and only 58% of patients received all 4 doses of Ipi. So is there a way to, you know, augment the trial to sort of maintain the Ipi dose intensity and density while getting the benefit? And so in discussion with Exelixis and BMS, we are going to have a total of 60 patients at this point in time, and we're going to actually amend the protocol to have a starting dose of cabozantinib 20 milligrams for the final 20 patients with the induction Nivo/Ipi. At the conclusion of that, if the patient is doing well, the dose of Cabo can then be increased back to 40. And so we're hoping to enroll those final 20 patients with any variant histology in the coming months. And I really want to thank all the investigators, Exelixis, and BMS for the support of the trial.
All right, in our last trial with Dr. McKay, a randomized trial of radium-223 and cabozantinib in patients with advanced RCC and bone mets.
Thank you so much. It's really an honor to present this study that I think is very near and dear to my heart, and so many of you all in this room have been involved in its generation. So, you know, this whole story actually started in the clinic when I was a fellow at the Farber with Tony, and we would see these patients that had bone metastases, and they all did very poorly. And out of that story, we kind of continued to follow that initial kind of gestalt in the clinic and actually demonstrated in multiple data sets through the IMDC, through a large clinical trials database, that actually these patients do poorly. They have worse mortality. They also have worse morbidity related to skeletal-related events, pain related to their disease, and bone metastases is a common site of involvement in RCC. We all know the activity of cabozantinib and its activity in the bone as a dual VEGF-c-MET inhibitor. Given our connection in the GU space with radium-223, around this time in 2013, radium-223 had actually gotten FDA approved for treatment of prostate cancer. It's an alpha-emitting radiopharmaceutical that has demonstrated improvement in overall survival for NMCRPC. We actually launched a small pilot study of 30 patients, which really was the genesis for us fueling the phase 2 trial through the cooperative groups. And in that pilot study, we had 2 cohorts of patients with de novo disease that were actually treated with frontline pazopanib, and those with refractory disease that were treated with sorafenib with the combination of radium. And we were actually able to demonstrate in that trial that we saw declines of all markers of bone turnover and formation, also demonstrated a signal of efficacy with decreased SSC events in those patients. And so we continued to follow the story even further and move that this concept into the radical study through the cooperative groups, which is now open and accruing. This has really been kind of a homebred concept. The trial is enrolling all patients with RCC having at least 1 or more untreated bone metastases with a KPS of 60. There'll be stratification factors based off of osteoclast targeted therapy use, which is actually required unless contraindicated on the trial. There'll also be stratification based on IMDC risk group, prior treatment status, and opioid use. Patients will be randomized 1-to-1 to receive cabozantinib plus radium-223 versus cabozantinib alone. The dosing of the cabozantinib during cycle 1 is at 40 milligrams, and in the absence of persistent grade 2 or grade 3 toxicity, the dose will be escalated during cycle 2. The primary endpoint is SSE-free survival, and you can see the secondary endpoints here of objective response, PFS, OS, bone response, and there's a series of imaging and quality of life biomarkers that'll be assessed throughout the trial. The trial is seeking to enroll 210 patients and has been well on its way. If you're involved in the cooperative groups, you can actually go onto CTSU's website, pull the protocol, and move it forward at your institution. We have many sites that have the study open. We do have an upcoming webinar jointly with Tian Zhang, the pedigree PI. Oh, there you are. And that's going to be happening on 11/2. So mark your calendars. We're happy to have you all be involved. Thank you. And this is sort of the whole, there's an army of people that have been involved in this whole process.
All right, thank you to the presenters. Awesome presentations. So we have 10 minutes left for questions. So I'm going to start with Nizar over there, Dr. Tanir.
Yeah, thank you. Question to Katie. Katie, are you concerned with the drug that you're using to block adenosine or alpha, that you're not blocking beta, and then it looks like, you know, the resistance mechanism for blocking adenosine or alpha is through upregulation of the beta? Would a strategy blocking both alpha and beta would have been a better strategy to combine with nivo-ipi?
Yeah, no, thanks. No, I think that's an excellent question and a fair point. You know, I think in testing in the setting of frontline in a triplet, to go for a quadruplet would have been a little bit challenging. But also, I think your point is a fair one. Which part of the adenosine signaling pathway is the best to target? Is it the ectonucleases that dephosphorylate ATP to adenosine? Or is it the receptors themselves? I think the preclinical data that we have with this drug is suggestive that the adenosine to a receptor might have some early efficacy, and so that was the one we went with.
Hi, Eric Singer, Ohio State. Fantastic panel. My question is more to everyone in terms of what we should be considering the optimal endpoints and comparisons we're looking for in our trials now. Given so many approved first-line agents and combinations, should we be looking at complete response rate as the goal we're shooting for, PFS, OS, and should we really be making sure that our comparisons are with one of the first-line current standards as we're looking to design our future phase 3 trials?
It's an excellent question. Maybe I'll put Katie on the spot because you guys have an unusual endpoint of deep responses rather than the typical ORR. So maybe you can talk a little bit about what discussion went into that decision.
Yeah, so I think the question is twofold. What's the best primary endpoint, and then the second part of that question, what's the best comparator arm, especially given kind of recent changing data. So I'll start with ours based on our somewhat different primary endpoint that we've designed for our frontline clinical trial, where we're looking at depth of response, and we did this based on kind of post hoc analysis done by essentially everyone here in this room at many of the frontline VEGF-IO or PD-1 CTLA-4 combinations that show that patients who achieve a certain tumor shrinkage, that correlates with long-term response. I think this comes into the quintessential question of drug development on a certain timeline, but also what's most meaningful to the patient. And what's most meaningful to the patient that's sitting in front of me in the clinic room is cure and durable response, and hopefully some time off treatment. So we're trying to strike a balance with our endpoint.
Yeah, I don't mind chiming in a little bit. I think, this is a panel of investigator-initiated studies that are not necessarily with a registrational intent. And I think a lot of these studies are signal finding, they're hypothesis generating, it's providing that early data to identify, justification for that large randomized phase 3 with your optimal control and what's your actually endpoint that's going to be an endpoint that's suited for registration. So I think we just need to temper that with the fact that these are essentially small IITs and kind of built off of the correlatives, that's embedded into all these. There are heart and soul.
I have a question. So I have a question for Dr. Ravi Suprafo. Thanks for your presentation. So especially with IITs, we always talk about biomarker endpoints, and we always strive towards biomarker-driven trials. And in your introduction, you did speak to subpopulations of kidney cancer that might be specifically susceptible to CDK inhibition, so 9p loss, CDKN2A, focal deletions. Do you anticipate, given the size of your study, that you're going to have a sizable population of those patients to the extent that you can actually look into that? And was there consideration to actually make that your primary population? Why wouldn't you have done that?
I think that's a very fair question. Obviously, with 25 patients, we're going to have maybe at most 10 who may have this biomarker, and it's really going to be very small to draw conclusions. However, given that there's loss of VHL, which should theoretically, at least mechanistically, lead to upregulation of cyclin D, these pathways, it's a reasonable target to go after. If out of those 10 patients, all 10 respond and we see some signal, perhaps there would be scope to further expand in that cohort. But practically speaking, to screen these patients, do a genomic test and get them on treatment, for a small IIT is difficult. So I think this is signal seeking. If we see something, then clearly that would be merit, further exploration in a larger biomarker selected cohort. There is preclinical data actually of single agent activity of palbo and abemaciclib in cell lines. I think Monty Pal had a paper in JCOPO in collecting duct where a patient with CDKN2A2B loss had deep response to palbo. It's N of 1, so hasn't been evaluated as far as I could see in a more in-depth manner.
There is data from jointly Bill Kalin and David Sabatini about CDK4/6 being a target by itself and perhaps a mechanism of resistance to HIF2 inhibitor, although in the paper it was HIF2 independent. Question for Dr. McGregor, removing the hat of the mentor here. I mean, with Nivo-Ipi people, Nivo-Ipi Cabo, with Cosmic 313, people have complained about toxicity. So one idea is what Tom Powell's presented with the Ipi dosage. every 3 months. Is there any other, ways introducing cabo at a lower dose, subsequently lower IPI dose for another cohort?
Yeah, I mean, absolutely. I think when we sort of saw the 313, and even anecdotally just enrolling patients on CAN, I was worried about LFTs, and so causing 313 confirmed that. And so the question is, how do we adjust further? I think there's different strategies. So one is reducing the cabo dose, one is extending the IPI dose. I will say that in discussions with the sponsors, the most acceptable, quickest option was to reduce the cabo dose. And in the interest of our patients to sort of change that strategy sooner, I think we went for that. But we had actually discussed going to the every 12 week, and maybe that would be something, fine, if there's a signal and we see that this subgroup of population really does have response, maybe we can think about an expansion cohort extending the IPI dose to the every 12
I don't
weeks.
know why if there is BMS folks here, I think it's not really great that no one is exploring IPI dosage every 3 months like the study of Dr. Powell's. It was randomized. It was in renal cell, specifically in clear cell, and we can't say this is randomized phase 2 and it's not appropriately powered because the toxicity was quite powered. So I think this is a sloppiness from the company, from BMS specifically, calling them out of not going with ipilimumab like that.
Yeah, I think to piggyback on that point, Tony, I think why to use the triplet, why to add the cabo into the backbone of nivo-ipi is to decrease that primary PD rate. You're playing the long game with the nivo-ipi, the short game with the IO VEGF, and so you have the luxury, if you can get them out of their primary PD with their IO VEGF, to space out the IPI. So, then you don't run into issues with toxicity, then needing to use prednisone, or steroids, which can mitigate efficacy.
Just a comment for Brad. Brad, I saw in your slide on the eligibility, you have included renal medullary carcinoma. Please do not.
So that was included in the initial program. We're not putting those on, but based on your discussion with you, I think,
Otherwise, Dr. Massawa will be upset with you.
In the Atezo-Bev analysis, we had a renal medullary carcinoma, but it was not like a sickle cell associated RMC. I think we had talked about this before, that it's not like the classical RMC.
I mean, that Andrea Apollo did the trial at the NCI, included all GU tumors, and there were a handful of patients with RMC treated with the triplet, and they didn't respond. So we know about RMC is actually, if anything, there is hyperprogression when you give them nivo-ipi. TKIs, as you heard today, we published that in European Urology in 2012. RMC does not respond to TKI. So.
I've had several sickle cell associated RMCs come through my clinic that have not gone on this trial in the past year. So yes, we're not looking for the sickle cell associated RMCs.
Okay, so with that, we're going to close the session. Thank you to our presenters, amazing presentations, good discussion.